Hello, I'm Donal Macaulay and welcome to this BMJ Leader conversation. Today I'm talking to Jan Frich. Jan, you've a remarkable career from clinical neurologist to a senior executive in hospital and health authority. Tell us a little bit about that journey and how you go from being clinician to being such a senior administrator in healthcare.
Well, thank you, Donal. It's been quite a journey, and I think it started for me with particular interest in patients' experience of care. Basically, I was very interested in trying to understand what was important for patients. So the first thing I did after having done my sort of internship was to actually do a master's of medical anthropology in London to try to understand more the social, cultural, aspects of how people dealt with their illness and risk. And I think when I started medical school, I think it was 1990, just the same year the Human Genome Project started. So I was quite heavily influenced by thoughts on genetic risk. So I wrote a PhD thesis on how to communicate about risk with patients, basically, because I felt that was one of the challenges I met as a clinician, trying to talk about statistics and probabilities, and trying to figure out how can this be said in a meaningful way. And from that starting point, I started working with doing a specialization in neurology. I started working with neurogenetic conditions and muscular diseases, and also almost 10 years I worked with at the National sort of Center for Huntingtons disease, which has been a main interest of mine. And during that sort of 10-year period, I increasingly, became aware of the systems that sort of framed in the clinical realities that I experienced. And I started studying health administration, and I became more and more interested in leadership, management, and then for quite many years I combined my job as a clinician with being a professor at the University of Oslo, teaching leadership and management. And then in 2018. Or basically 2017, this opportunity came up to really take on a role as a sort of senior leader in the regional health authority that sort of contracts hospitals and owns hospitals. My idea was to try to have an impact on medical care, and try to do my best. So after a 2-year-long pandemic, after 5 years in that position, I felt the need to get back to patients, but get back to where it all happens, and then I took on this job as a CEO for a general hospital in Oslo, Diakonhjemmet Hospital, which so I've been in that role since August 2023.
I'm really intrigued by your interest in medical anthropology. That's so unusual. Tell me more about that and what you learned and what you experienced and what it brought to your career after that.
I felt, as a young doctor, I felt a need to understand more. I felt the need to try to broaden my toolbox, basically. And one of the things I learned was that there is potentially a gap between the clinical world, the doctor world, the medical world, and the world that people live in, basically, where they experience and think about their illnesses. And one of the insights that I got from studying perceptions of risk was that people reasoned about their own risk in ways that I haven't learned about in medical school. I mean, we learned statistics, we learned averages, we learned predictions. But what I found that in terms of genetic risk, people would often refer to the family histories. They would reason like this. They would, for example, say, so my father got this when he was in his mid-50s. but he smoked and he did not exercise as much as I did. So let's say my risk is that I would probably get trouble in the mid-60s. It's a more analogical way of trying to make sense of uncertainties. And I think to trying to understand the world of patients, and those worlds may differ also. I mean, some patients are probably also quite statistical in their reasoning, but it's sort of the clinician's job to try to accommodate and try to understand what's important. Because if you basically if you don't talk the same language, if you don't understand each other, any attempts to try to, install treatment would be difficult. So this was one of the insights that I learned from doing this master program, and also learned about issues like shame, guilt, also themes that we didn't learn so much about in medical school, and also how people would try to make sense of illness in different ways. So I think it broadened my sort of toolbox, it broadened my perspectives on what we're doing and what's important to people.
So I'm looking at two ends of a spectrum. The clinician, epidemiologist, statistician at one end, and the humanities at the other. But it's triangular because there's a third component to your career, and that's the business administration. Tell me a little bit about that training.
Well, it's I think it basically started with a huge frustration. As a clinician, I wasn't prepared. I didn't understand how this system was basically designed. We had wards being shut down because the economy was bad, and I didn't have a clue about why these things happen. So I think that really motivated me to try to understand more. How are these services financed? What are the expectations in terms of legal requirements, etc. So after quite many years as a clinician, I also realized that you could be like a meta clinician trying to, lead on in a reasonable way, and that sort of engaging in leadership is also it's one aspect of being a doctor, but if you work at a different level. So I've sort of invented this concept to try to give myself a sort of identity, so that I'm now like a health systems doctor. Okay, I'm a doctor for health systems, trying to, do reasonable things in health systems, but then acknowledging that, where the rubber hits the ground is where the clinician meets patients, and my job is try to, do the best I can to make those meetings as good as possible.
Now, this brings us very nicely to talk about your Harkness Fellowship, which clearly was inspiring.
Yes, yeah. So I had the opportunity to become a Harkness Fellow with the Commonwealth Fund in the US in 2013-14. Spent a year based at Yale School of Public Health and studied leadership in health systems, basically, and also how leadership was developed, or the system's initiatives and programs to develop leadership capacity. So what I soon realized that you could think about leadership in two distinct ways. You could think about this as developing individual leaders, or you could think about leadership development as developing a capacity within a system. So, and leadership development can be both. The one doesn't exclude the other, but I think you need both perspectives to build strong organizations that has a commitment and has a sense of direction and leadership. So So that was I had the opportunity to travel around, talk with people in major health systems in the US, and basically embed myself in how, you know, how do you do this? How do you target different professional groups? For example, should you see doctors as a special case, or should they, you know, be part of development initiatives for everyone, etc. So there's a lot of questions in this field, and basically, I think one of the insights is that so far the sort of leadership component hasn't been very large in professional, you know, medical and health education, nursing education, and I think we need to have initiatives and programs in place to build that capacity, you know, as for clinicians. So you just can't take it for granted. You need to have something in place to actually strengthen your systems. Yeah.
Which brings me to one of those key questions. I guess it applies to clinical leadership as well as anywhere else. Are leaders born or made?
That's a classic question. Well, I think the sort of correct answer would perhaps be both, but I think for the most part, leaders are made. I mean, there are some there are some personality traits, etc. you can associate with leadership capacity and potential, but I think what the literature says is that around 80% of it all is based on actually learning and doing, reflecting. It's a capacity you can develop and build.
Let me talk to you about something slightly different. It's still within the business of communication and leadership, but that's your role as editor of the Norwegian Medical Journal. That was really an unusual turn in the road of your career. Do you think we're doing a good job in medical communication?
Yeah, I think so. My role was to be a medical editor for a couple of years in the Norwegian Medical Journal, and it was almost 15 years ago, and it was an important part of my career. You know, I think to communicate and disseminate knowledge, and to also reflect on what that knowledge means, is an important role for medical journals. So what does this mean in this particular context, you know, the local health system context, the Norwegian healthcare system? So I've been I think international journals are very important, but I also see the importance of having national or local journals debating, discussing the uptake of new insights. I mean, today we have a lot more information available than we could dream of. So we communicate a lot, but I think we have to communicate wisely. We have to sort of frame messages and frame knowledge, and well, it's a difficult question to sort of respond to, I think, but I think that having an ongoing dialogue of what new insights means is really important for a society.
Thinking back on all the different components of your career and looking at how these all come together, my final question is, where to next?
Well, I haven't thought so much about that. I mean, I've just taken on this role, and there's a lot of things to do here. So I have no other plans than just trying to do my job the best I can at this hospital. I mean, it's a prestigious hospital. It's on the Newsweek list of world's best hospitals, and we need to just ensure that we, you know, keep the good reputation, keep the high quality, and sort of strengthen our system so that we can meet the future.
Yeah, and it's been an absolute pleasure talking to you, and thank you for sharing so much of your life and experience with us. And I've learned a new term and a new career, and that's that of the health systems doctor.
Yes.
Thank you very much indeed.
Thank you. You're welcome, Donald. Thanks.